Thank you, Dr. Ndagurwa, for the kind introduction. It's always difficult to be introduced by your mentors, but thank you for that. And I'm also going to present after my mentors who mentored me in the fetal medicine fraternity. So I'm going to talk about fetal growth restriction, and it's going to be harder and harder, as Mr. Zanga just said, but I hope people are going to grasp it. So the outline of my presentation, we are going to define fetal growth restriction, highlight the extent of the disease burden, assessment of risk and surveillance. I think these words are going to be repeated over and over again. Risk assessment, surveillance, risk assessment, surveillance. Then recognize phenotype of fetal growth restriction, diagnosis and management. Then I'm going to conclude. So on my first slide, you saw that this presentation was co-authored by one of the fetal medicine gurus who is not around, and she usually presents. So it's a great honor for me to present this presentation, which we co-authored with Dr. Hlachwayo. I would want to reference her name in absentia. All right, so what's the definition for fetal growth restriction? It's a fetus who is failing to achieve its genetically predetermined potential. So it's difficult for us to know the potential of a baby, how they are going to be growing when they are in utero. So this is a functional definition which seeks to identify fetus at risk of modifiable but otherwise poor outcomes. So we are saying if we look at our growth charts, it puts people into the nomograms, where if you are, Mr. Zanga kind of touched on it, if you are above the 10th centile to the 90th centile, you are within the growth spectrum where everything is expected to be normal. But if you are small like me, you might be found below the 10th centile, not meaning that I am not okay, but I'm just small. If you are also good enough, you can be found on the Zanga end, where you are above the 98th centile, right? So the difference between normal and abnormal, it's always a transition. So that's how we are going to be dealing with this condition. Having said that, we are talking about fetal growth restriction, but there is a confusion between fetal growth restriction and small for gestational age. But the statement which I just said, I would explain it later. So small for gestational age used to be defined by size of biometry. So we are just measuring the size, and if Marangwanda is small, you are called a small for gestational age, and if someone is bigger than me, probably people think that they are better. So it has been said that small for gestational age are those babies which are below the 10th centile. It doesn't mean that they are abnormal in any way, but we are saying if we take the average of the population, they fall below the 10% of the average population. So small for gestational age is not synonymous with FGR. I already had my Bamnin who used to say, if you see me short, it doesn't mean that I was cut short. This is me. So it doesn't equal that if we have a small for gestational age, there is pathology there. So within this group where we have babies who are below the 10th centile, there are three distinct groups. Those who are constitutionally small, like me. Then those who are pathologically small, when Dr. Chris Chirume was presenting, he was talking about those trisomies and the like. So genetic disorders, they can actually then present with small babies later on, which is pathologic. Then the small starving fetuses, which is the main concern of our discussion now. So many fetuses who have fetal growth restriction actually are found in the small for gestational age category. This statement, you should take it seriously. Then it means if most babies with FGR are found in the SGA category, it means we also have babies who have fetal growth restriction who are not found in the what? In the SGA category. So having a normal weight doesn't mean that you don't have fetal growth restriction. Okay. Not sure what's happening now. Okay. Okay, so hence the diagnosis of small for gestational age is useful in identifying those babies who are at risk of having fetal growth restriction. So some fetuses with fetal growth restriction may not be small for gestational age, and you are going to see this as I continue with my presentation when we come to diagnosis of fetal growth restriction. Now it's not moving. Okay, the slides are not moving. So you don't need to be short and start to have challenges. Then you become fetally growth restricted, isn't it? You need to be short and active and present your presentation flawlessly. But thank you for fixing the technology. I think I can use this. Can come here. All right, so having said what I have said, here we have this graph which is trying to explain what I have been saying. So we have small for gestational age and intrauterine growth restriction on this graph. Then you see that this graph is falling below the 10th centile, which then fits what people are used to. Then we can have a patient with intrauterine growth restriction but not SGA. So if we come to this graph, you will see when I present later on in terms of the definitions. So this is the group which I was referring to. You can have a baby born with a weight of 3.7 or a born with a weight of 2.7, for example. They are above the small for gestational age mark. However, they might actually be having fetal growth restriction. Then we have the small for gestational age, but not growth restricted. So here is me, right? I have been below the 10th centile from conception until delivery. All right, so our challenge as clinicians is to identify those fetuses with fetal growth restriction whose health are endangered, both intrauterine and the life after. Remember, fetal growth restriction then predisposes these little babies to non-communicable diseases like gestational, like diabetes mellitus, later on hypertensive disorders in pregnancy. So by the same token, we should recognize more, but not health, but health fetuses and avoid iatrogenic harm to these fetuses. Imagine my mom being delivered at 34 weeks because people think that I'm not growing properly. Probably she would have missed the doctor then because maybe I was not going to make it, since prematurity is the commonest cause of perinatal mortality. So traditionally, identifying women with pre-existing factors of FGR, that is what we used to use. I think Dr. Verenga kind of highlighted in this. So traditionally, we were using the priori risk to say you might have an FGR baby, but as times are going, we are now becoming more and more specific, and Mr. Zanga just presented on the usefulness of Dopplers, and now more recently we are now using Doppler velocity and placental biomarkers to really diagnose these babies. So we can use the uterine artery pulsatility index to allow us to integrate, to interrogate the uteroplacental function. Normally in pregnancy, as alluded before, the end diastolic flow in the umbilical artery should be increasing. But if you see that it's not increasing as predicted, then you increase your surveillance and probably manage these babies with fetal growth restriction. Investigations can be started in the first trimester and help us identify those babies who are at risk. I can't overemphasize on these points which have been presented before. The speakers before me spoke about these biochemical markers, the PAP-A, which we can use as risk stratification methods to say, how are we going to manage this mother with a low PAP-A and other issues which we'll be seeing in our screening protocol. So the benefits of screening is that we can intervene and try to minimize the consequences of this disease by giving low dose aspirin, which should ideally be started before 16 weeks. I think we have other presenters who are going to go into detail about these issues. So if we want to quote studies, now we are in the era of evidence-based medicine. The aspirin study, which was looking at aspirin in terms of prevention of preeclampsia and the likes. You can get some nice references there if you are someone who likes to read. So we should all start surveillance so that we risk stratify our women. I am talking mainly about FGR, and start aspirin at an appropriate age so that we either prevent this disease or at least minimize the risk to this unborn baby. So what's the importance of surveillance? It helps us to identify fetal growth restriction early, assess the rate of clinical deterioration, plan for appropriate interval of next or when we should act, and decide on the timing and place of delivery and the mode of delivery. So not all babies can be delivered at a clinic, not all babies can be delivered at a district hospital, not all babies can be delivered at a provincial hospital. Some babies are better delivered where they are best cared by. So it helps us to transport this baby in time. So tools for surveillance, we can use longitudinal growth charts to enable us to determine deviation of growth. We can also use the Doppler velometry. I'm not going to go into detail now because when we come to the definitions, I think I will come back to these details. So we should recognize two phenotypes of fetal growth restriction, which are determined by the gestational age at which this diagnosis was made. So there is early onset and late onset fetal growth restriction. So if fetal growth restriction happens before 32 weeks, it's early onset. If it happens after 32 weeks, then it becomes late onset. What is the prevalence? So late onset fetal growth restriction is more common than early onset, but a lot of people think that it's otherwise. So late onset fetal growth restriction is actually more common, with 70% constituting 74%. And when we do ultrasound, you will see that these fetuses, when we have early fetal growth restriction, they are usually very small, but those ones with late onset fetal growth restriction might not necessarily be small. So Dopplers, in terms of the early ones, there is alteration that involves the umbilical artery, medial cerebral artery, and the ductus venosus. And usually these vessels are affected in that order. But when you look at those fetuses which are going to have late onset fetal growth restriction, they might actually continue to have a normal umbilical artery Doppler, but start having issues with the medial cerebral artery, where we usually used to read in our scans to say there's brain sparing effect and the likes. Unfortunately, this was commented after just doing the umbilical artery Doppler, which is one of the things which we are correcting now. So hypertensive disorders is frequent with the early onset and not so frequent with the late ones, which are usually the consequences of early maturation of the placenta and the placenta giving up early before actual term. Then placental histopathological findings. So poor placentation happening in the early one and less specific with the late ones. And perinatal mortality is high with the early onset if you compare it with the late onset. Then we come to the diagnosis. of fetal growth restriction, we use the Delphi consensus. I'm going to take a little bit of some time. So we'll start with the early onset fetal growth restriction here, which we said it happens before 32 weeks. So small for gestational age is fetal weight below the 10th centile, full stop, right? But we say a lot of fetuses who are growth restricted, they fall in this category. And what is fetal growth restriction? If it's early, if it's those babies who are going to have an abdominal circumference or estimated fetal weight which falls below the 3rd centile. So our ultrasound scan machines, they will, if you go to the graphs, I think yesterday people were being shown how to scan and the likes. If you go to the graphs, they will then categorize these babies according to their centiles. The machine can tell you that. So early fetal growth restriction in abdominal circumference or estimated fetal weight below the 3rd centile. If you find that, it diagnoses fetal growth restriction. Or if it's a small baby, or what you think that it's small for gestational age, you now need 1 or 2 of these Dopplers to be deranged for you to then diagnose fetal growth restriction. So for the babies who are below the 10th centile, you need an abnormal uterine artery Doppler or an abnormal umbilical artery Doppler. So for all those babies who just fall below the 10th centile, we are going then to then say, are they just small for gestational age because they have normal Dopplers, or they are actually they are having fetal growth restriction now because one of these or both of these Dopplers are abnormal. Then if we go now to the late onset fetal growth restriction, you will see that the abdominal circumference and the estimated fetal weight below the 3rd centile, it still diagnoses fetal growth restriction. However, it becomes more complex with the late onset fetal growth restriction, because when we come now to the less than 10%, it also involves other things. So if the baby is below the 10th centile, which is a small for gestational age, you also need other things to be present, which are the abnormal Dopplers. Or this is a baby who is within the normal growth range. However, they are deviating from their growth pattern or velocity by more than 2 quartiles. So we are saying this baby is still within between the 10th and the 90th centile. So I will give an example where a baby has been growing around the 80th centile from conception. At 25 weeks, you see that the baby was at 80%. Then they come at 32 weeks, probably you do a scan and you see that now they are at 60%. Then you do another scan, you see them at 40%. Naturally, they are still within the 10 and the 90th centile in terms of their weight. However, their growth is faltering with more than 2 quartiles. So it then diagnoses that this patient is carrying a fetus with fetal growth restriction. Besides that, the weight is still within the normal ranges. So being big doesn't mean that you are the strongest, isn't it? I can be small, but being the strongest. Then you can also use now the cerebral placental ratio. So we are saying with the late onset fetal growth restriction, we said we are having the placenta not being able to support the growth of this baby. So what's going to happen now is this phenomenon which we have been talking about, the brain sparing effect. So you are going to have more blood flowing to the brain so that we spare the growth of the brain. So if we do the middle cerebral artery and compare it with the umbilical artery, we are going to see that their ratio is going to be abnormal, and it can also be used to diagnose fetal growth restriction, especially in the late onset fetal growth restriction. So here, I think I'm not going to dwell much on these fetal Dopplers, but we have different scenarios where scenario 1, FGR, normal Dopplers, you can have different scenarios when we have a baby with fetal growth restriction. So scenario one is a baby who has fetal growth restriction, but they have normal Dopplers. You can scan them after every 2 weeks. Then we can have a baby with fetal growth restriction, and the Dopplers above the 95th centile, you have to see them after every week. And scenario 3 is now you are having abnormal Dopplers where you have absent or reversed EDF in the umbilical artery. You scan them after every 3 days, and I don't want also to preempt into other people's presentations, but you see that for those who have been reading around, if you look at these patients, you are looking at them whether they are after 32 weeks or before 32 weeks in terms of when you are going to deliver them. So this slide, I just included it to highlight how you are using the Dopplers, to say when you are doing a uterine artery Doppler, you are just looking at the placental function. Then when you do the umbilical artery Doppler, you are looking at the placental resistance. I think Mr. Zanga tried to highlight on that. Then the middle cerebral artery is telling you about the fetal adaptation, which is happening, and the ductus venosus. Remember, the ductus venosus is a shunting of blood which is going directly into the cardiac chamber. So if there are issues with the placentas and the likes, it's going to mirror into the heart of this baby. So it then tells you the compromise within the heart of this fetus. So decision to deliver, we usually use the TRAFO study, and the criteria is that before 32 weeks, we only deliver fetuses with fetal growth restriction if we have an abnormal ductus venosus Doppler, which is an absent A wave or a reversed A wave, as depicted by those pictures there. I think Mr. Zanga touched on these Dopplers before. Then if it's after 32 weeks, so abnormal Doppler criteria after 32 weeks, we then use the umbilical artery. The ductus venosus, you can use it before 32 weeks. After 32 weeks, we are no longer using the ductus venosus. We are now using the umbilical artery to determine when to deliver these babies. So if a patient continues to have high PI in the umbilical artery, or let us start with FGR with normal Dopplers, we are going to let this baby to get to term and deliver them. Then if at any gestation delivery is indicated, the following are present. So maternal indication such as preeclampsia, HELP syndrome, and obstetric emergencies, they then take precedence to your Dopplers. Because remember, when you are managing these patients, it's either you are managing the maternal complications or you are managing the fetal complications. But most babies with fetal growth restriction, in our setting, we are going to deliver them via cesarean section for the issues of monitoring and the issues about CTG. But I want to applaud the FMU, because yesterday I also saw people were being trained in the use of CTG. But you see that most of our fetal growth restriction, because of our monitoring in our hospitals, we will better deliver them using cesarean section. So screening uterine artery Dopplers velometry at 11 to 14 weeks and at 18 to 22 scan. Then commencement of aspirin before 16 weeks for those whom we would have diagnosed as high risk is going to help us. Then monitoring is done at our tertiary institutions, I hope and believe that this is the scenario in Bulawayo. Unfortunately, we are not really using CTG for delivery, and we should also know that CTG doesn't have a role to play in the surveillance of fetal growth restriction. If you want to understand more about this, you can go and read on the study which I have mentioned before, the TRAFO study. Then give a course of dexamethasone and magnesium sulfate for the appropriate ages, depending on when you are going to be delivering these babies. And as I have alluded before, most babies in our situation with fetal growth restriction, we are going to go for cesarean section for a simple reason that our monitoring during labor is not yet up to scratch. So in conclusion, the diagnosis of fetal growth restriction is not always straightforward. And let's all be vigilant when we see pregnant women so that we risk profile them, start them on aspirin if they need to be on aspirin, and put them under surveillance so that we diagnose this disease early. And early diagnosis of fetuses with fetal growth restriction will help us to closely monitor them and to determine when it's best to deliver them. I think this is the end of my talk. Thank you very much.